Welcome to ACLS Med. Today we're managing a critical case of second-degree AV block type 2. This is one of the most dangerous bradyarrhythmias you can encounter, and it requires immediate intervention. The patient is Robert Martinez, 65 years old, male, weighing 78 kilograms. Current setting is in a hospital bed on a cardiac care unit. Robert came to the emergency department this morning after experiencing a syncopal episode at home. He fell to his knees without warning, struck his head on the kitchen table, and lost consciousness for approximately 2 minutes. Chief complaint: syncope with head injury, chest pain, and a very slow heart rate. History: Robert has a history of acute myocardial infarction 3 weeks ago, treated with percutaneous coronary intervention and a stent to the right coronary artery. He also has hypertension and chronic kidney disease stage 3. He takes metoprolol for his heart, lisinopril for blood pressure, and aspirin for antiplatelet therapy. Critical detail: 3 weeks post-MI with inferior wall involvement. The inferior wall is supplied by the right coronary artery, and the AV node is also supplied by the right coronary artery. This means his AV block is almost certainly secondary to his recent cardiac event. He is at extremely high risk for progression to complete heart block. We are not going to wait. Let's begin our assessment. Robert is alert and oriented, but pale and anxious. He complains of chest discomfort and says he feels dizzy. His skin is cool and clammy. His airway is patent. His lungs are clear bilaterally. He is breathing spontaneously. His vital signs are alarming. Heart rate is 42 beats per minute, but that is not the whole story. Blood pressure is 88 systolic, 56 diastolic. His oxygen saturation is 94% on room air. Temperature is 37.2 degrees Celsius. Respiratory rate is 14 breaths per minute. On physical examination, his skin is pale and diaphoretic. He has a large bruise forming on his forehead from his fall. His peripheral pulses are weak and very slow. His capillary refill is 3 seconds. His blood pressure is dangerously low for a conscious person. Now let's examine his cardiac monitor. This is critical. We see a rhythm that looks, at first glance, like a slow, regular rhythm. But look more carefully. We see P waves. The first P wave is followed by a normal PR interval and a normal QRS complex. That is normal. Then we see the next P wave. This P wave is not followed by a QRS complex. It is completely dropped. There is no conduction. This is a dropped beat. Then the rhythm continues. The next P wave is followed by a normal PR interval and a QRS. Then another P wave is dropped. This pattern is diagnostic. Some P waves conduct to the QRS, and some P waves are suddenly blocked without any warning. There is no progressive PR prolongation leading up to the dropped beat. It is sudden. It just happens. This is second-degree AV block, type 2. This is Mobitz II. This is different from the bradycardia we saw in our last scenario. This is not a sick sinus node that is beating too slowly. This is a conduction block at the AV node. The atria are generating P waves, but the ventricles are not receiving every signal. And this is dangerous. Mobitz II has a high risk of sudden progression to complete heart block, where the ventricles stop beating altogether. This patient can arrest without warning. He is symptomatic. He has syncope, he is pale, he is hypotensive, he is diaphoretic. His altered mental status from the syncope is resolving, but he is still altered. His perfusion is poor. Applying the ACLS bradycardia algorithm, is the rhythm bradycardic? Yes, 42 beats per minute with a non-functional dropped beat every few seconds. Is the patient symptomatic? Yes. Are the symptoms caused by the bradycardia? Yes. This is a symptomatic bradycardia with hemodynamic compromise. But there is one critical difference from sinus bradycardia. Mobitz II often does not respond to atropine. Atropine works on the SA node and enhances AV nodal conduction through the vagus nerve. But in Mobitz II, the problem is not at the level of the SA node, and it is not vagal. It is a mechanical conduction block at the AV node itself. Atropine often fails. However, we still give atropine as first-line therapy. We have to try. First, let's stabilize the basics. We establish 2 large-bore IV lines, 18 gauge. We apply supplemental oxygen to target saturation greater than 94%. We place Robert on continuous cardiac monitoring. We notify hospital command, cardiology, and we prepare the ICU. We also notify the pacing team because we will almost certainly need a pacemaker. Now we administer atropine. We draw up 1 milligram of atropine, which is 1 milliliter of the 1 to 1000 concentration. We flush the IV with saline and push the atropine IV rapidly over 1 to 2 seconds, followed by a 10 milliliter saline flush. We watch the monitor carefully over the next 30 to 60 seconds. 30 seconds have passed. We reassess Robert. Looking at the monitor, we still see the same pattern. Second-degree AV block type 2 at 42 beats per minute. The dropped beats are still occurring. There has been no improvement in the conduction. His vital signs are unchanged. Heart rate is still 42. Blood pressure is still 88 systolic, 56 diastolic. He is still pale and diaphoretic. The atropine has not worked. This is what we expected. Mobitz II does not respond to atropine in the vast majority of cases. This patient needs immediate pacing. We do not have time to wait for a second medication. We do not have time to debate. Robert is at risk of sudden complete heart block at any moment. He could arrest. We need transcutaneous pacing right now. We expose Robert's chest and prepare the skin. We place the negative or white pacing pad on his right anterior chest wall, just below the right clavicle. We place the positive or red pacing pad in the 5th intercostal space at the mid-axillary line at the level of the nipple. We press both pads firmly for 10 seconds to ensure good contact. We connect the pacing cables to the defibrillator pacing unit. Before we initiate pacing, we give Robert analgesia and sedation. We administer midazolam 2 mg IV push and fentanyl 50 micrograms IV push to blunt his anxiety and pain during pacing. Now we set the pacemaker to demand mode at a rate of 60 beats per minute. We begin at 0 milliamps and gradually increase the output, watching the monitor and palpating for a pulse. We increase to 20 milliamps, no capture. We increase to 40 milliamps, still no capture. We increase to 60 milliamps. We see it. A pacing spike appears before the QRS complex on the monitor. The rhythm becomes completely regular. Every beat is now paced. We check the femoral artery and feel a strong pulse at 60 beats per minute, regular and synchronous with the pacing spikes. We have mechanical capture. The pacemaker is working. Robert now has a dependable heart rate, delivered by the pacemaker, not by his damaged AV node. Let's immediately reassess Robert. On the monitor, we see a paced rhythm at 60 beats per minute. Every beat has a pacing spike before it. The rhythm is completely regular. No more dropped beats. The AV node is bypassed. His vital signs show immediate improvement. His blood pressure is now 94 systolic, 62 diastolic. We can see it rising already. His oxygen saturation is 95% on supplemental oxygen. His skin is becoming warmer and less pale. He is more alert. The syncopal confusion is clearing. He is answering questions appropriately. Transcutaneous pacing has immediately restored his heart rate and improved his perfusion. This is the correct treatment for Mobitz II with hemodynamic compromise. However, our work is not finished. Robert is now paced, but he still has a damaged AV node. He still has the underlying problem that caused the Mobitz II in the first place, which is his recent inferior myocardial infarction. We need to arrange for transvenous pacing or a temporary pacemaker. We need to discuss with cardiology whether he needs a permanent pacemaker, and we need to prepare for the very real possibility that his AV block was a harbinger of a larger problem. We keep Robert on the transcutaneous pacemaker in demand mode. We leave the threshold set at 60 beats per minute, so if his intrinsic rhythm improves, the pacemaker will stop pacing him. But if his AV block returns, the pacemaker will immediately take over. We order a 12-lead EKG to assess his MI. We order labs, including troponin, electrolytes, and renal function. We notify cardiology for an urgent consultation. We prepare Robert for transfer to the ICU for continuous monitoring and discussion of transvenous pacing or temporary wire placement. Let's review the key teaching points from this case. Second-degree AV block type 2 is a medical emergency. Unlike Mobitz I, which is often benign and may never require pacing, Mobitz II is dangerous. It represents a conduction defect in the AV node that can suddenly progress to complete heart block. This patient can arrest without warning. Mobitz II typically occurs in the setting of acute inferior myocardial infarction, as in this case. The inferior wall and the AV node are supplied by the right coronary artery. When that artery is blocked or damaged, both the inferior wall and the AV nodes suffer. Atropine is ineffective in Mobitz II in most cases. Do not waste time waiting for atropine to work. If your patient is symptomatic, move immediately to pacing. Transcutaneous pacing can be placed in minutes and provides immediate rate support. It is a bridge until you can arrange transvenous pacing or a permanent pacemaker. The critical learning point. Recognize that Mobitz II is not just a slow heart rate. It is a conduction problem that can be life-threatening. Act decisively. Pace early. Prevent sudden asystole. Robert is now stable on the transcutaneous pacemaker. His perfusion is restored, and he is on his way to the ICU for definitive care. This is ACLS in action. This is recognizing danger and acting fast.
Integrated, immersive, essential. ACLSmed.com